Do you know that sometimes it takes up to 10 years or even more for the proper diagnosis of bipolar disorder to be established?
Krka Talks podcast, where we share knowledge and personal thoughts with healthcare professionals and the general public.
Hello everyone, I'm Piotr Wierzbiński. I'm psychiatrist from Poland, from Łódź. It's a big city in center of Poland. And it's a great pleasure for me to introduce Professor Ante Silić from Croatia, from Zagreb. It's a big city in Croatia. Every people in Poland know where Croatia is because it's our favorite holiday destination. And now we are going to talk about the bipolar disorder because it's very interesting disease, and the epidemiology of bipolar disorder is quite interesting. We talk about pharmacology and we talk about all interesting things for our clinical practice.
Thank you for this kind introduction. I feel very humbled to be in your company here. Yes, you said it right. We'll talk about bipolar. I find it very important and interesting topic because it's probably one of the diagnoses that is most commonly, I would say, missed.
I agree with you because we have many patients who suffer from unipolar depression and they have no unipolar. They suffer from bipolar depression. So could you explain us and say something about the predictors factors for bipolar depression? Because in routine practice, in normal clinical practice, usually we see the depression patients.
We do have to be aware of the fact that bipolar patients present themselves to us and they seek for contact, for help, majority of the time while being depressed. They do not feel like they need help while they are manic. Mm-hmm. And then there is also that important period of time where they are asymptomatic. They don't suffer from any symptoms. So it kind of explains why we do make that error in judgment or differential diagnostics, because the split in time clinical presentation of a depressed patient who is uni versus the one who is bipolar, there are virtually no differences. There can be two identical patients, one suffering from uni, one from bipolar disorder at the split time in the moment. But with all the anamnestic and heteroanamnestic data, with all the questions that we should ask, the checklist that you actually asked me, is something that we should ask every patient every time, whether they had experienced periods where the mood was elevated a little bit more than usual, a little bit more than normal, which is a difficult question because nobody thinks that the mood is too high. Everybody enjoys it and everybody misses it once it passes. But still, that's the area where we can profit from the data that our patients' spouses or brothers or sisters or children or co-workers will give us. And then with that question asked, also an important one should be there, such as the onset of the symptoms. The earlier they start, there is a more of a risk that the patient suffers from bi versus unipolar. Psychoactive substance abuse, which is also an important question. There is some, let's call it self-medication in the area of unipolar, but the numbers are much, much higher in the bipolar. Then the comorbidity, such as personality disorder or also some comorbidities with some schizophrenia spectrum disorders, because bipolar is somewhere in the spectrum, somewhere between unipolar or schizoaffective disorder, and as such, it can have its highs and lows.
And if we observe the natural history of bipolar, so the hypomanic episodes of manic episodes are rather shorter and the depressed are longer.
Yeah, more impressive.
Yeah, so you think that this is the problem for diagnosis because the people don't want to say to the doctors that they have transient hypomanic episodes, yeah? This is the problem.
Yeah. I think that they don't see it. There is such an issue in this important topic in this area is stigma, but stigma of bipolar is a little bit significantly higher than the one of the addiction to alcohol, than the one of pure depression, unipolar depression, because many, let's say, celebrities have spoken openly about addictions, about depression, but not so many about other psychiatric disorders.
Yeah, but what about suicidal rate in unipolar versus bipolar depression? Could you explain us this? Because this is the serious problem, I think so.
Absolutely. That's one of the most important differential diagnostic issues. We are not persisting to be as precise as possible, as early as possible, just so that we can be academically clean or therapeutically clean. We are insisting on that area because the risks related to the wrong or delayed or not even ever established diagnosis in bipolar is directly linked to the high suicide rate of attempts and unfortunately of successful attempts. So that's something that should be taken into consideration very early on.
So everyone knows that your passion is neuropsychopharmacology and the receptors, etc. So tell us something about the treatment, because the treatment is could be very effective. And if our patients with bipolar are treated with effective drugs, the long-term treatment could be very effective and improve the quality of life. Yeah. Tell us something about the drugs.
Yes, thank you. That's my favorite area of.
I know it.
After the differential diagnostics, then we have to think early on in the treatment about the long-term outcomes, about the results that we tend to achieve, about the functionality and recovery and prevention of suicide. So, lots of things to think about. A logical question that arises is there a drug that can actually combine and check all the boxes? And especially so because we do prescribe antidepressants in bipolar disorder. This is one of the areas which is very much debated upon because literally if you were looking by the book, I mean, you wouldn't be allowed to do so. But our patients suffer, our patients are depressed, even though they are bipolar. But we should kind of visualize it in a way that antidepressants maybe do have room in treatment of bipolar, but a very narrow one. Also, the next maybe logical step would be a mood stabilizer. But it covers not so big area as a typical antipsychotic does. Widest area is covered with, for example, quetiapine, that covers both manic and depressed phase, that is a good mood stabilizer, and that can actually cover from short-term outcomes to mid and even long-term ones.
Why quetiapine is effective in bipolar?
I would like to say that exactly the molecule is built like that it has different affinity and different effect on different receptors regarding to the dose and regarding to the formulation. There is immediate release and extended release one. So basically in the bipolar, I mean, you cannot generalize and there is no one rule that fits everyone. You always use individualized approach to the patient, obviously, but some mid and high range doses, it covers even dopamine for the psychotic levels of symptoms, either manic or depressed ones. It covers serotonin reuptake, noradrenergic reuptake, if you are thinking about the active metabolite of quetiapine. And it covers also the H1 receptor. So it's a polypragmatic molecule in one molecule. I do have a lot of high amount of good experience with quetiapine in this area of therapy. So basically, all the bases are covered. So that should answer your question. I think so, yeah.
So, but, you know, many people who suffer from bipolar disorder ask us as a psychiatrist, should I take these drugs
whole my life?
Well, people resent the idea of psychotropic medications, each and every one, especially if we are talking about the psychotropic medication that should be taken long term. And once the bipolar has started rolling, it's close to a lifetime. Huge issue in bipolar also is compliance. That comes with close with insight and with stigma and with everything that we tackle, all of those issues during the treatment process. But it's a long-term therapy. And then I draw a lot of analogies when I try to explain to each and every patient how long will it be. Well, I said, for example, I'm taking hypertension medicine, and I did not ask my cardiologist how long. It most probably lifetime. Maybe they will change it at one point to something else or not, but I'm trusting my cardiologist, and I'm doing the regular checkups, and I take my medication, and so it resonates differently with different kind of patients, but still it helps a lot to be very, very personal in the approach and in the explanation while answering that important question.
Tell us, what about the patients who drink alcohol, use many substances, and the interactions? So the people ask me, is it serious interaction or not? Doctors, what can you tell me?
If they come to the point where they ask the specific question about the interactions with alcohol or THC or whatever illegal or legal substance they are talking about, they are asking for a friend. They are not asking for themselves. That's a start. We should have a good rapport. We should have as honest, as clear communication as possible, but we should be aware that patients most of the time will not share all of the details, or at least that we do not understand them correctly. How much of confidence does a patient has at each point to share the important details? It's a different story. We are trying to limit the benzo prescription rate in Croatia, which are sky high, through the roof. But still, basically, everybody takes benzodiazepines these days. So, psychoeducation, therapeutic alliance, honesty, and patience, that's something that usually works.
To conclude, let's make some summary. The key important facts about bipolar disorder, useful for our routine, our practice.
Yeah. If I had to summarize in a couple of sentences, maybe first thing that would be of importance is to think early on about possibility of bipolar diagnosis, even when somebody presents as depressed, as unipolar, and ask every patient, every family, every time in order to differentiate that. And then after that, I think the second most important thing would be to think about long-term treatment and the long-term outcomes early on in the treatment. Because we do have the luxury of having the huge range of psychopharmacs. So we tend to sometimes aim and shoot at the symptoms and not maybe think about the long-term outcomes. In this context, I would say that the story about using antipsychotics as mood stabilizers should come early on in the treatment, thinking about the long-term outcomes. And thirdly, but also not least important, is to have in mind why we are doing all that, because the quality of life is awful for bipolar patients, especially in depressed phases, and to have in mind the huge risk of suicide. So basically, that's a very important some topics about the bipolar that I would like to underline.
Okay, thank you for nice talk. Thank you for everything, and see you soon. And you can watch us in another podcast. I think so.
Yeah, thank you very much for having me. Thank you.
Krka, because we stand by you for health, knowledge, and motivation.